time Dr. Ullhas M. Pandurangi from India. He will talk. Yes.
Can this lecture slide seen? I cannot see. I can see only the stamped like.
Everything is perfect, sir. Probably it's your internet. Can you?
Okay. Let me re-log in.
Yes.
Leave and re-log in.
Okay, thank you. Dr.
Yeah,
Ullhas M. Pandurangi will be talking on role of remote monitoring for the management of heart failure patients. Dr. Ullhas is the Chief of Department of Cardiac Electrophysiology and Pacing from Institute of Cardiovascular Diseases, Madras Medical Mission, Chennai, India. He is a faculty in a number of international conferences and editor and reviewer of different prestigious journals. Dr. Ullhas, please, you can share your screen and can deliver your space.
Hello everyone. I hope my screen is clear.
It's fine, sir. You can go.
Thank you. Hello everyone. It's my privilege to be participating in this Bangladesh Society of Cardiovascular Interventions. And I thank the scientific committee for giving me this opportunity. Today I'm going to be talking about how the implantable devices could be monitored remotely and how this remote monitoring of these implantable devices help us to manage our heart failure patients better. So far we have heard about the drugs and the devices. Now, sitting in your office, how can you also help your patients who are at home or even on travel by going through the data that you obtain from their implantable devices, how you can make their life better is the gist of my presentation today. We all are aware that there's been a significant advancements in the pacemaker technology. The pacemakers have this tremendous capacity to store so much of data pertaining to the rhythm per se, and there are certain data which could be surrogate pointers of patient's activity and the cardiac efficiency in the form of day-to-day activities, heart rate variabilities, pulmonary congestion, including even the cardiac pressures, etc. So much of a data which is stored in the pacemakers or the implantable devices, all of which, when it is digitized, in this era of internet and increasing mobile usage, it is just possible to send without any contact the data that is stored by the Bluetooth technology to some of the devices which can be connected to a central server through the internet or through the mobile technology. That constitutes the remote monitoring. For example, a patient here, maybe at home, maybe on travel, has an implantable device, either through the internet technology or through the mobile technology, goes to a central server very securely in an encrypted fashion. At the vendor's web server, it is further analyzed and that is sent in a readable format to the physician's office, to the physician's assistants, etc. And then you can take certain actions depending upon the data that is delivered. The technology has been found to be so very effective that the most of the cardiological societies across the globe, including the rhythm societies, have recommended very strongly that the remote monitoring should be the part of the care of the patients with the pacemakers. They give a class 1A recommendation for this technology. Almost all the vendors of the devices have come with the remote monitoring technology. In the country today, we have all the major manufacturers like Medtronic, Biotronic, and Abbott. Elsewhere, even Boston also has brought in the remote monitoring technology. What I have heard is that it is making some initial steps into the Bangladesh. I think soon Bangladesh will also adopt this remote monitoring technology because as my slides unfold, its utility will be highlighted. Typically, remote monitoring technology helps the heart failure patients more than those patients who have been given for their bradyarrhythmia support. Why is that? It's because what is the standard way we treat our heart failure patients? I would call the way we treat our heart failure patients is a reactive fashion. That means patient comes to you either to an office or to the emergency with heart failure, and then you start treating these patients. This is the general trend. With the remote monitoring, what happens? You can actually make a proactive therapy because the heart failure admission or a visit of the patient to you occurred because there were certain abnormal things which are happening before this. Only when the summation of those abnormal things hit the threshold point, patient becomes symptomatic. For example, if there is an arrhythmia going on, for example, if the activities of the patients are coming down, or if you think there is some increase in the lung congestion, all of this, if you could monitor by some means, you can treat the patients at this stage itself, not necessarily at this stage where the prognosis becomes worse. So remote monitoring will give you an opportunity to treat your heart failure patients proactively and avoid the hospitalization. I will show some examples. The remote monitoring technology would give you an idea about your patient with an implantable device, whether he has had any AF episodes, how long, what was the ventricular rate during the atrial fibrillation, is the lung congestion is increasing, is the patient's activity is coming down, are there any other surrogate pointers towards the lessening of the cardiac efficiency in the form of heart rate variability, etc. And if the patient has biventricular pacing device, and then we know that more than 90 to 95% is an optimal pacing. If there is a decrease in the pacing of the biventricular pacing incidence, are there any arrhythmias which are going to be causing potentially lethal VTVF, and he is going to get the shocks, etc. All this you could figure out before the patient develops florid heart failure. The technology also is friendly. You could individualize the kind of the alert what you would like to have from the patient. Are you interested in the PVCs which the patient is suffering from? You would like to have some atrial monitoring, atrial rhythm monitoring. You would like to look at even the kind of ventricular arrhythmias. You can individualize the alerts what you would get, or you could get all kinds of the informations. And then you could also individualize when you would like to be alerted, on what particular event you would like to be alerted, which you could attend urgently. And what are those alerts? For example, you can make something as an yellow alert where your response is not going to be so immediate. That is the theoretical part. What is the evidence that the remote monitoring actually had benefited the heart failure patients? There is an immense amount of data that has been published over the last 2 decades. And for example, if I quote this meta-analysis in the forest plot here, more than 1 million of patients into the trials and the registries who have been followed up a minimum of 2 to 3 years of duration, almost all those observations have suggested that the patient with the device, if he has been monitored remotely, does far better than that patient with the device without remote monitoring. So there is enough data, and that is why I think most of the societies have strongly recommended remote monitoring to be added to your pacemaker therapy. I would like to quote quickly some examples where we thought we made our patients with heart failure live better and their quality better. We run in the country the largest of the remote monitoring center. Thousands of our patients have been followed up here in the last 10 years. Case number 1, for example, in ischemic cardiomyopathy, one had bypass surgery, etc. He has had a CRT implantation, a biotronic device, in the year September 2018. This is a typical example how proactively you can make his life better. How was that possible? For example, on 3rd July 2021, we received this. The CRT pacing was temporarily below 95%. That is an alert. Our patient with the CRT, we are supposedly to be not allowing them to have less than 90 or 95%. So now there is an indicator that you've got to do something. This is from July 2nd. It is saying so accurately because every single beat is being monitored. So you'll be able to say since when this started happening. So we know that there is a CRT less than 95%. It also is telling you that the patient is developing PVCs. So if this is the issue, on top of that, there's something else is coming up here, that there is an LV threshold measurement repeatedly failed in the past few days. It calls for an action. So further analysis of the data, it is telling that it is coinciding, the CRT pacing events are actually less when the PVCs are more. So there's a direct correlation here. So if you treat this PVCs, probably you are going to be getting the BIV pacing better. And then you call the patient now because this is the time. Now look at this ECG, which is really not a nice ECG for a CRT patient. And if you remember, there's an alert that there is something to do with the LV pacing threshold. So it's clearly there is a loss of pacing from the LV. So you call the patient and then you take some proactive measures, and maybe you increase the pacing thresholds, pacing output. Maybe you treated his heart failure. Maybe the PVCs came down, and then this is what was supposedly this patient was to have. Maybe the patient is going to be doing well. So case number 2 is another diabetic non-ischemic cardiomyopathy case here. And the patient has had a CRT-D implant, and this time this is St. Jude Gallant, which has a Bluetooth technology, very convenient these days to have your patients to be connected with their own mobile phone rather than having an additional gadget. So this is the other advancements in the remote monitoring technology. Patient, device, and just their own mobile phone, no other gadgets in between. Well, this was the intrinsic rhythm, a classical case for a CRT, and it was kept neatly, I believe, because the result was great. And the very same day, his device was connected to his mobile phone. That was on 4th of September 2020. And within the first 48 hours, the reports start coming in. Things are all going on well. Biventricular pacing more than 99%, things are okay. And on the 6th day of the post-implant, even though there was no alert, our alert physician assistant looks into the details further, and then she finds that not all is well, because the biventricular pacing is 47%. The device did not alert because it is waiting for another 24 hours to give an alert. But because your team is alert, and when it is seen, even though there is no alert, this makes us to get into the data again remotely into the actual electrograms, atrial electrogram, a right ventricular electrogram, a far field electrogram. It looks like all of them are in the same line. Maybe it's a junctional rhythm, and that is why there is no biventricular pacing here. But this is quite unusual that the patient never had this kind of episode in the past. What could be other differential diagnosis? Within the few days of an implant, if this A and the V are coming simultaneously, there can be a possibility that this A has fallen into the V, and that is why they are recording simultaneously. Which got confirmed and looking at the ECG, because this is not junctional rhythm. You have a P wave and a QRS, but the P and the QRS are happening at the same time. in the electrograms obtained by the leads, then the only thing that could be that the atrial lead has fallen in. The patient was discharged, and if you could get this as an alert, well, you could call the patient much early and then put it instead of waiting for 1 month of your regular follow-up time. And this is how you could actually help your patient. Even and of course, your active participation is required in this remote monitoring because even though there is no alert, you are looking into the electrograms. Lead reposition and things went on well. I hope it does well. Case 3. This is a single chamber implant for the documented VT in a case of ARVT. The state that there is, of course, you can put your alerts into various forms. For example, there's an yellow alert comes. Why there's an yellow? Why this is called an yellow alert? Because there was an VF detected and it's treated, so everything is okay. If you have an episode, for example, a VF, so far the patient did not have such a thing, and if there was a therapy. And then if you look at whether the therapy was truly an appropriate therapy, there's an opportunity to assess it remotely. It says ATP delivered, and then the shock is aborted. Great stuff. So the device did very well. However, what are the opportunities for you to make him feel good or to continue to be not to be perturbed with this kind of alert? And that is to look at the data, whether it is appropriate or not. Indeed, this is appropriate, and shock was aborted. You could actually tell the patient that the device had done well, and maybe sometimes these ATPs may not work, and he may get a therapy which could be painful. So you are actually alerting him to be prepared and not to get really shocked psychologically. And many a times, when we had predicted this, and then within few days, when they have had actually a shock, their reaction or their reaction to that particular therapy was much more mild than other patients who do not have this kind of remote monitoring technology. When suddenly they get it, they really get into a panicky mode, which I think everybody knows. So if you are preparing the patient and telling them in advance that he may get a therapy, there is this opportunity to make him mentally more prepared. Case 4 is ischemic dilated cardiomyopathy who has had a VT for RFA, VT, and then he had a RFA, and then post RFA he also had an ICD. This time this is Medtronic and moderate LV dysfunction. We get an alert. There was one shock, and you look at it again. The remote, the traces we obtain from the remote monitoring, they are as good or probably of a better quality than what you see in your office or in your pacemaker clinic. There's an opportunity to assess whether it's appropriate or not. Great. So this all looks appropriate, and even if the patient has got shock, even before he calls us asking what has happened, you could also actually in advance before he calls you, you or your team could inform him that we know that he had a shock and that actually saved his life. So this kind of a reassurance could be possibly given by the remote monitoring technology. Another case, idiopathic dilated cardiomyopathy, and this time this was a Biotronic. He also had a RFA for VT. What does it say? For example, here the LV lead failure is detected. What is that LV lead failure detect? There is a further explanation of this observation, and that is there has occurred switch from the bipolar because of certain impedance issues to unipolar. Well, this is the time for you to take an action. Patient is totally unaware. If this switch has happened, probably there's kind of a damage that is taking place. Today, fortunately, the unipolar is going on, but the same pathology may extend, and then the unipole could also be involved. So this is the time that the patient should be called in and an active intervention could be done. And then that's what was done. You call the patient for the visit, and then maybe you will have to counsel that the LV lead is a problem, and then you may be replacing it. So remote monitoring not only postpones their visits or avoids their visits, but sometimes proactively you can actually call the patient before they're scheduled in office or pacemaker clinic visits. One of the last cases which I'm going to be showing how useful this is, not only to look at the events, but sometimes you can take certain active measures. For example, here, remote monitoring and the magnet has actually made somebody feel good here. And how is that possible? There was a remote monitoring transmission. It was a red alert. And what was the red alert? It's really very alarming. 11 ineffective shocks were delivered on 26th April 2021 when there was total lockdown in our city, Chennai. There was a pandemic, the extreme form of the pandemic wave during that time. 11 ineffective shocks. And then if you look at this, what was actually, why there have been so many ineffective shocks? An atrial electrogram, there's a ventricular electrogram, you clearly see there is V, and then on top of that, the T, this is a double count that is happening, and the device is looking this as a VT or a VF, and then the shocks are going on because this process will continue. Patient will continue to receive the maximum number of the shocks. And further history, the patient was COVID affected. He's in the ICU on a ventilator, and then nobody is sure what was happening to the patient. We were several kilometers away from that particular COVID ward. When we see this, we call up the nurse attending, and then we send a magnet to the nurse there who could apply this magnet on the device, and the inappropriate shocks were avoided. So remotely, sometimes it's possible to take some active measures. Lastly, remote monitoring, how does it help? I think this is one of the good things to follow. And what is that? Remote monitoring enables you to continuously monitor, and it alerts you if the patient, there are no messages received for the last 3 days. For example, you can fix it. If there are no messages, that means patient has not charged the unit, or maybe the mobile phone is away from the patient, etc. And this is an alert, and then you could actually make the patient to be connected, and then inform the patient that now that the patient is paid for this device, let that be used optimally. So even when the patient is not in touch with you, you will be knowing the patient is not in touch with you, and make them be in touch with your clinic. So I think if somebody asks me a question, which modality will allow constant connect with the patient of a sick patient who is a heart failure patient, and which is that modality which will also alert you if the patient is not in touch with you, I think this is remote monitoring. I think we should all adopt this technology.
Dr. Ullhas, we are running out of time.
Yes,
Can you?
so the last slide, it's cost effective. I think we should adopt. Thank you, sir.